Hi everyone, thanks for joining us today. My name is Karl Richardson. I'm a general cardiologist at Wake Forest Baptist Health, and we're here to talk a little bit about heart health today. And later, sneak peek in about 10 minutes, we're going to talk a little bit about AFib. So in my practice, I take care of patients with coronary artery disease. That's disease of the heart arteries. I take care of patients with heart valve problems, some patients with heart rhythm problems, and some patients that I see are just here to discuss their risk of having a heart problem. Now, a lot of us at Wake Forest Baptist have a number of interests, and I'm the same as a lot of us. I consider myself a general cardiologist, a preventive cardiologist, and I'll talk a little bit more about what that means. But I also have a special interest in valvular disease, and so I spend a lot of my day in the ultrasound lab looking at ultrasounds of the heart or echocardiograms. And I also am an educator. I have an interest in medical education, and if on Tuesday afternoons, for example, you can find me over at the medical school. And in the hospital, I work a lot with the resident doctors, with the residency program. And at work on a regular basis, like I said, I'm a general cardiologist to take care of patients' hearts. And I like to focus on kind of two basic concepts. First is a straightforward and comprehensive approach to people's known heart disease. And then second, what I feel strongly about as an educator, I like to try to first fully understand for myself what's going on with patients' hearts and any heart disease they have. But in some ways, even more importantly than that, I think it's important that patients know what's going on with their heart. So many times I see patients that don't quite understand why they're on medicines that they're on or why they're getting procedures that they're getting. And one of the things that I focus on in the clinic a lot of times is why we're doing what we're doing and how what we're doing can help my patients. So what would this look like? If you come to see me and you've had a heart attack, we discuss what that means and what we can do to change your risk of having another heart attack, or what we can do, what medicines we could use or lifestyle changes we could use to avoid that. If you have a heart valve problem, what we would do is discuss what testing we need to do to figure out or to sort out how severe that valve problem is, and then we discuss what procedures might need to be done, if ever, to fix that valve problem. Or maybe you come to see me just to discuss your risk of having a heart attack. Maybe you have a family history, your mom or dad had a heart attack, and then we would talk about what could be done to reduce your risk of having a heart attack. Now, in medicine and cardiology for general, we talk a lot about risk, and what does that mean? You know, we know some people are at high risk for having a heart attack, and some patients are at low risk, but you know, what do we do with that? And in clinic, what I do is I talk a lot about risk. So, for example, are there changes in your lifestyle or changes in your medicines that we could make to take you from that group of patients that has a high risk of having a heart attack and change that such that your risk is actually lower? Or is there testing that could be done to better understand that risk? For example, is there an EKG, an electrocardiogram, or an ultrasound, an echocardiogram, or a stress test that we could do to understand if you're high risk for having a heart attack or low risk for having a heart attack? And finally, are there medicines or procedures that we could discuss that could change that risk? So anyways, that's a lot of what I'll talk about in clinic. And the next thing that I kind of wanted to talk about was if you were to come see me, what are the type of things that you might expect to hear about? The different things that affect your heart health, for example. So first and foremost, blood pressure and cholesterol. And we always talk about know your numbers. And what does that mean? Blood pressure, knowing what a normal blood pressure is and what your blood pressure could be or should be. And cholesterol, knowing what a normal cholesterol level is and what a cholesterol level for you, depending on what type of heart problems you have, what it should be. And so I talk with patients about that. Blood pressure and cholesterol. Blood pressure, you know, your heart's a pump and it's pumping against pressure. The higher the pressure in the body is, the more strain that puts on the heart. And the arteries are like the pipes in the body, and the higher the pressure is in the pipes, the more strain it puts on the pipes. And so together, pressure on the heart and pressure on the arteries of the pipes can lead to things like heart attacks and strokes. Same with cholesterol. The cholesterol causes blockages, and blockages in either the heart arteries or the body arteries can cause heart attacks and strokes. And so I think it's important for patients to know their numbers, and then for us to talk about where your numbers should be based on what types of heart problems you either have or you're worried about. Second thing I talk with a lot of patients about is smoking. I know we're in Winston-Salem. I know obviously a lot of people smoke here, and I also know that it's not straightforward to quit, but I also know that it's really important to at least talk with patients about this. And I think a lot of patients, everybody knows that smoking is bad for their heart, but I think some patients don't realize that it's never too late to quit. And if you do quit, in just a matter of years, your risk is back to where it would have been if you had never smoked for certain types of diseases. And so that's something that I focus on a lot with patients, depending on what's going on with them. And recognizing also that not everybody can or is ready to quit smoking, but that's something that we continue talking about. Next thing I talk about a lot of times is diet. We all know that diet affects the heart and affects your heart health. Things like fried foods and salty foods, we know we should try to limit as much as we can. But what I think a lot of patients don't realize is that things like fruits and vegetables, while they're healthy, they can also lower the cholesterol. Also, certain high fiber foods can lower the cholesterol. Certain things like nuts, tree nuts, and fish can raise the good cholesterol. And so depending on what your numbers are and where we want them to be, we can work together to figure out what the right diet would be. Finally, I talk about exercise. Exercise, I think, is something that's underappreciated. Maybe say that, I don't mean to laugh, but I guess I think exercise is really important. What I tell patients is I want them to be intentional about it. And so what does that mean? That means doing something for the sake of exercise, not just being active at work or with the kids, but picking something that you enjoy doing and doing it as much as you can. And there are a couple reasons for that. One is it's healthy for the heart, it's healthy for the body, and it can contribute to weight loss. But importantly, a lot of my patients have had heart disease or may in the future, and if you do have a condition that leads to going into the hospital, being physically fit can get you out of the hospital faster and can help you recover from that quicker. So I think that can be really useful. And the other thing is, if you are at risk for a heart problem, but you don't know it yet, people that are physically active notice it sooner because they're putting their heart through that strain before someone who is not as active would. So you can see this is just kind of a little snapshot about what we've discussed and what goes into my thought process when I'm taking care of patients and their hearts. And each patient's plan is different. And once you come and visit me, we would talk about what's going on, what your numbers are, and figure out what balance of medications, lifestyle changes, and testing we can use to affect your heart health. And then sometimes there are more specialties needed, and I work with a number of colleagues who you're going to get a chance to meet one in just a second. Maybe you have an electrical problem with your heart, and we need to talk, work as a team to figure out the best way to deal with that. And so I'd like to introduce here Dr. Beaty. He is an electrician, and I think he's going to talk a little bit about what it would look like if you had a heart rhythm problem. Dr. Beaty?
Thank you very much, Carl.
Of course.
So as Carl was saying, he works on the pump, he works on the valves, he also works on blood pressure. So you can think of Dr. Richardson as a plumber for the heart. Think of me as the electrician for the heart. I deal with different abnormal rhythms from the top and bottom chamber of the heart, including atrial fibrillation, ventricular tachycardia, and SVTs. We are also the specialists that put in devices to treat both tachyarrhythmias, or very fast rhythms, as well as bradyarrhythmias, or very slow rhythms. But today I'm going to use my time to talk more about atrial fibrillation. It's a common disorder that many patients are affected with. About 6 million people in the United States are affected with atrial fibrillation, and that number is going to go up with time, including up to about 15.9 million is estimated by 2050. So with that, when we talk about atrial fibrillation, some people know about it. You may have family members that have AFib, or you may have AFib yourself. And in that case, you would see either me or one of my partners. So I have my little Mickey Mouse version of a heart right here. So normally you have a bundle of cells in the top right-hand chamber that may cause the heart to beat anywhere between 60 and 80 beats per minute. However, in atrial fibrillation, there's a abnormal rhythm that's coming from the left side of the heart. These 4 open circles right here represent the veins that lead blood back from the lungs to the heart. They can have extension of heart muscle cells that start to fire on their own. When they start to fire on their own extremely fast, it starts to pick up the speed and causes the heart to beat irregularly as well as very fast. And in that situation, that's where we come into play. So with atrial fibrillation, there's no absolute cure for AFib. There's just better management. And so when we talk about better management, we focus on about 3 different concepts. The first one is what we call stroke prevention. Because the top chamber of the heart is beating so fast, it can cause blood to stand in one place for too long. And if that blood pools too much, it can cause a clot. If that clot breaks off, it can cause a stroke. So in our case, what we try to do is determine your risk factors for stroke and then put you on the right blood thinners to try to prevent that clot from forming and prevent a stroke itself. So when we evaluate somebody's risk for stroke, we have a certain score. And in that score, there are certain risk factors that are controllable, others that are not, that increase or decrease your risk for stroke. So on this 9-point scale that we have, which we call the CHADS-VAS score, if you have 2 or more points, you're considered a high risk for stroke. You say, well, what is the CHADS-VAS score? The subcomponents include if you have heart failure, if you have high blood pressure, if you're over the age of 65, you get a point. If you're over the age of 75, you get another point. If you have diabetes or have a prior stroke, you also get another 2 points for prior stroke. Also, if you have any kind of vascular disease, prior heart attacks, any kind of peripheral vascular disease, that gives you another point. And also, unfortunately, if you're female, that also puts another point on that scale. So once again, if you have 2 or more points, you're considered high risk, 1 point intermediate risk, and 0 points low risk. If you have 2 or more points, then that's when we start to talk to you about some of the anticoagulants that are out there. You may see some of those on TV in ads already. Those may be some of the newer blood thinners, such as rivaroxaban, dabigatran, and apixaban. In addition to blood thinners such as those, there's also the age-old warfarin. But here at Wake, we also utilize special technology that can prevent your risk for stroke without having to be on blood thinners. One of those includes the Watchman device. Now, you may have seen ads on TV for this. You may have also looked online for this procedure. What this procedure does is decrease your risk for stroke without the long-term use for anticoagulants or blood thinners such as Coumadin. And it has been proven that it is just as effective as Coumadin for preventing strokes long-term. Actually, I have a couple of images behind me that may show the placement of the Watchman device. At the very top middle screen that we have right here, what we're doing is we've already gone from the right-hand side to the left-hand side of the heart, and we've injected contrast into that area. Well, after we deliver this kind of parachute-shaped structure into the left atrial appendage where most clots form, it walls off that, and so now you can see all the blood is bouncing off of that parachute type structure, that Watchman, and going to the rest of the heart, preventing where 90% of clots form. So that's decreasing the risk for stroke. That's the one thing about AFib that can negatively affect your lifespan. The others are more quality of life issues. The first thing that we do is try to keep your heart rate under control. And we usually try that with medications. And medications can work very well. If medications are having a difficult time with controlling the heart rate, sometimes we do different procedures to slow down the heart rate and put in pacemakers. Here's an example of a pacemaker. For the most part, pacemakers may sit in the upper left-hand chest, right in this area, underneath the skin, underneath the fat layer, but above the muscle layer. And then there are leads that go down into the heart that keep your heart rate going at a good speed. But here at Wake, we also utilize further technology, and some of the newer technology that we have includes this leadless pacemaker. Now this leadless pacemaker, as opposed to being inside the vasculature with a lead, this is actually implanted into the heart, and it's left there, and it has all of the electrical activity as well as a battery to work as a single chamber pacemaker. So we implant this in the bottom right hand chamber of the heart, and it does all the work, and this can last for up to 12 years. The great thing about this thing is that there's no risk for complications from pocket infection, and there are no risk from lead perforations either long term. So once this is in the right location, it works just like any other pacemaker. Now it does have kind of a limited scope of indications, meaning that we can't put this in every single person, but if you meet certain criteria, we can actually consider implanting this. Now if you can see in the top left-hand corner, top right-hand corner of the screen, that's an example of one of these small leads that looks like a little fish hook implanted into the heart. What it does is it lodges into the little heart muscle, pieces of heart muscle, and implants in this area to keep everything in place. So once that's in place, it's functional, and you're left with nothing except for a little hole in your groin that closes up after about a day. So we've talked about stroke prevention, we've talked about rate control. If your heart rate is under control and you're protected from stroke, after that point, we're trying to control your symptoms from AFib. When controlling symptoms from AFib, once again, we always try medications first. And we may even do a cardioversion, which is a shot to reset your heart back into a normal rhythm. But if medications don't work, or if repeat cardioversions do not work, then that's when we come into play again. We use catheter-based technology to try to maintain sinus rhythm for as long as possible. For AFib that kind of comes and goes, the success rate of maintaining sinus rhythm with some of our catheter-based technologies is anywhere between 70 to 75%, whereas medications may last up to 40 to 60% of the time. For those who have been in AFib quite some time, the success rate is a little bit lower at 50%. But if we can give you the best opportunity possible to maintain a good sinus rhythm, we will try that, weighing both the risk and benefits. So when we talk about trying to get you back into normal rhythm, we typically use two different types of technology. One is what we call radio frequency technology, or in simple terms, that is a heated tip probe. The other one is a balloon technology, or in simple terms, a freezing balloon. So what we end up doing is, if I can pull up my illustration again, we try to create a scar around the openings of those veins that I was talking about earlier. So what we do, it's hard to do this upside down, but I'll try. Well, I'm doing a pretty good job. All right, so what we do is we electrically isolate the activity inside the veins so that they can't get out to the rest of the heart. And if I can do that, or if we can do that and make sure that those lines that we create are solid, then that gives us the best opportunity for maintaining sinus rhythm long term. So once again, there's no absolute cure for AFib, but there is better management, and we have the technology to do that. And one last thing, as far as that freezing balloon goes, here's an example of that freezing balloon. Initially it's deflated, but once we get over to the left-hand side, we end up plugging up the openings of the veins, turning on the freezing, creating the scar, and then after all the scars are created, everything comes back out of the body and you're left to heal. So with that, I think that we can open it up to questions, and I'll bring Dr. Richardson back into view so that both of us can answer whatever questions may arise.
Thanks, Dr. Beaty. So we got a great question, which is about diastolic dysfunction. And this is something that comes up all the time. What is diastolic function and what is diastolic dysfunction? And it's actually a diagnosis that's mostly made on ultrasound or echocardiogram. And what that is that's telling us about how stiff the heart muscle is. So we know that the heart muscle squeeze function is good, but people that have diastolic dysfunction have a stiffer heart muscle. Although that sounds scary, the reality is that a lot of people have diastolic dysfunction, and in some ways it's kind of like arthritis. Like if you live long enough, you're going to have some arthritis. It's kind of the same way with diastolic dysfunction, is that almost anybody over the age of 60 or 70 has some amount of diastolic dysfunction. The question is that diastolic dysfunction causing symptoms, and is that diastolic dysfunction contributing to other heart problems? And that's really the question. Some people, the question I think in this particular case was about life expectancy, and I would say normal. Someone with diastolic dysfunction has no change in their life expectancy, but the question is how is that diastolic dysfunction interacting with the other things? And that's something that we could discuss in clinic depending on what else is going on, but certainly wouldn't be worried about that in particular. I think we have a couple other questions here that Beaty can answer.
So the next question is, can atrial fibrillation cause VTAC, or ventricular tachycardia? In certain situations it can. So for the most part, atrial fibrillation is a very disorganized rhythm from the top chamber of the heart. We have a special conducting system called the AV node that slows down most signals coming from the top to bottom chamber of the heart. So usually, even though the heart's beating fast, the top chamber of the heart may be beating 300, 400 times a minute. The bottom chamber is beating about 150, 180 times a minute. Yes, that can feel bad, but usually that's because of the normal electrical conduction system. There are certain situations, such as if somebody has an accessory pathway, where you may have heard the term WPW. In that situation, a lot more signals get down from the top to bottom chamber of the heart, causing the heart to beat a whole lot faster, and that can be that ventricular tachycardia or even ventricular fibrillation in that situation. Another question is, how can a device detect atrial fibrillation? Well, I showed you the single chamber pacemaker device. Well, sometimes we put in both single chamber and dual chamber pacemakers. When we put in a dual chamber pacemaker, we have a lead that goes to the top right hand side of the heart as well as the bottom right hand side of the heart. That top right hand side of the heart does two functions. It can pace, but it can also see what's going on in the top chamber of the heart. So if you are in atrial fibrillation, these devices are very smart. They can see how fast the heart rate is going and trigger that to detect the atrial fibrillation. We are able to tell how fast the heart is going, how long you've been in AFib, and which days you're in AFib and which days you're not in AFib. Now also with those single chamber pacemakers, a lot of them do have different algorithms or programs that can detect the irregularity of the heartbeat, and by that it can detect the atrial fibrillation as well. Well, yeah. Well, with that, I'll let Dr. Richardson close.
Well, yeah, thanks for joining us, everybody, today, and we're happy to answer any other questions that you have. I think you can just post them on the site, or you can call us. If you have any other questions or you want to get an appointment, you can call 716 or 336 area code 716 WAKE. That's WAKE.
Thank you very much.
Thanks, everybody.